تفضل دكتور عبدالرزاق، وشكرا جزيلا لوقتك وجهدك، جزاك الله خيرا.
No problem. Aisha, thank you very much for inviting me to give a talk. What I'm going to do today is talk about coagulation emergencies. So as a coagulation expert, these are the sort of emergency we get day in, day out. Just before I start, I'm going to do a bit of introduction about myself and where I practice. I work at Imperial College Healthcare in London. Imperial College Healthcare is formed of several hospitals, including St. Mary's Hospital, where I am based, Hammersmith Hospital, Queen Charlotte, and Charing Cross, in addition to the Western Eye. About 18 months ago, we had London Northwest Hospital joined as a group, and currently I'm the head of department for all the hematology sections in these hospitals. I started as a consultant hematologist for St. Mary's Hospital in 1998, and I've been here since. St. Mary's Hospital is a very well-known medical institution for the heart of West London. We're next to the Edgware Road, اللي هو يسموه في شارع العرب يعني. And this is highly known institute. This is a very famous scientist who used to work at St. Mary's Hospital. I don't know if any colleagues may recognize this person. This is Alexander Fleming, who discovered penicillin. His laboratory actually is on the second floor of the university building, just opposite the hospital. معلش الشوكولاتة ياخدها بعدين، سكر الفون. These are some of the other famous researchers who actually practiced. So Rodney Porter was awarded the Nobel Prize for identifying the immunoglobulin structure. For those who have some cardiology affiliation, Dr. Walla was one of the persons who actually discovered the 12-lead ECG. Now, this hospital is very famous because this is where all the royal children are born. This is Prince William, who was born in 1982. Subsequently, his son, also born at St. Mary's Hospital. When I say St. Mary's Hospital, there's a private wing which is associated with the government hospital, National Health Service. This is the most recent addition to the family. You can see William is getting older and he's losing his hair. So this is the most recent addition to the family. And this is the staff at St. Mary's Hospital. There's a long list of famous people who actually were born in the hospital. Most of them are royal personnel. So we're going to switch now to our talk. As we know, normal hemostasis is a balance between two different components. These components are coagulation proteins. These result in the formation of the blood clot, and then a thrombus is formed. And on the other side, you have the fibrinolytic pathway, which results in dissolution of the blood clot. And it's the balance between these two sides of the equation which maintain normal hemostasis. Platelets play a very important role in the initial stages of the coagulation. Now, in order for the blood clot to stop forming, there have to be some form of what we call physiological anticoagulants. So physiological anticoagulants, in addition to the fibrinolysis, are formed from antithrombin. This is very important protein. This is how heparin function as an anticoagulant by augmenting the effect of antithrombin. And then we have the protein C, protein S pathway. This is formed by several components, including thrombomodulin, which is activated by thrombin, recruiting protein C, and also endoplasmic protein C receptors. Once activated protein C is formed, it does two functions. the first function is to inactivate activated factor 8 to inactive factor 8, and inactivate activated factor 5 into inactive factor 5. Now, a lot of you who practice hematology will know what we mean by activated protein C resistance. Activated protein C resistance is where this pathway, breakage of factor 8 or factor 5, becomes inefficient. The commonest cause of activated protein C resistance is the inheritance of factor 5 Leiden. So factor 5 become an abnormal molecule and it become resistant to the breakage by the activated protein C. So thrombin plays a very important role in activating this pathway. So a blood clot is formed at the same time the blood clot breakdown is activated in order to maintain that balance. Now, I've mentioned already how antithrombin function, how heparin interact through antithrombin. Heparin makes antithrombin about 1,000-fold more active by binding, and this is the basis for heparin being used as an anticoagulant. Heparin have several areas where it can interfere with the coagulation activation. The most important is inhibition of activated factor 10. And this is the basis of anti-10A assays we use for monitoring heparin therapy. Now, that's what happens in the body. So this pathway, the activation of factor 7, which initiates the coagulation, and then the formation of thrombin and the initiation of the protein C, protein S pathway and the antithrombin, is what happens in vivo. This is what happens in the test tube. Once you put a sample of blood in an anticoagulated tube, factor 12 is activated, and this gives you this what we call waterfall cascade, which result in eventually in the formation of fibrinogen. By mimicking this into in vitro, we can actually monitor these components of the coagulation pathway. The prothrombin time is what we use to monitor the factor 7, or what we call the extrinsic pathway. Activated partial thromboplastin time is what we use to monitor the intrinsic pathway. And then thrombin time and fibrinogen is what we use to monitor what we call the common pathway. What I'm going to talk about now is what are the common coagulation emergencies one is expected to see in clinical practice. And there are two types. There are conditions which present with the thrombotic complications, and there are conditions which would present with bleeding or hemorrhagic complications. I'm going to start with emergency which present with thrombotic complication. The commonest is one is this condition. This is a clinical scenario of a 24-year-old woman who's 21 weeks pregnant. She presented acutely with abdominal pain, fever, and reduced responsiveness. She phoned the ambulance. She was brought over to the emergency department, and this is her initial blood test results. Her hemoglobin is 75 grams per liter, or 7.5 grams per deciliter, depending on which units you use. Her platelet count is 19,000. Her white cell count slightly raised. Her prothrombin time, ABTT, and fibrinogen all within normal range. The question now is, what would be the next urgent investigation would you recommend? I'll be very happy to take any answers from the audience. I think it will be very helpful if we can make this as interactive as possible, rather than me talking all the time. So what would be the next investigation one would do for something like this?
عبدالرزاق تسمح فيها؟
نسمع فيك مهدي. نعم.
طبعا I'm a surgeon. I'm really fascinated by the lecture because this is way out of my field. But as a surgeon doing liver transplants, what it comes to me, especially if it's late, a little bit late, because she's only 21, I would think of liver functions to make sure that she's not having pregnancy complications of her liver. But the platelet count 19,000, that's what attracted my attention.
Yeah, so I think liver damage during pregnancy associated with thrombocytopenia is definitely a differential diagnosis. I think I'm looking for relatively severe, rarer types of blood conditions which can be associated with this phenotype. I think that the most important information here with such severe thrombocytopenia, her coagulation screen is within normal range. So I think
Oh, I'm sorry. I'm Hanan Hamid from Egypt. Dr. Abdulrezaq, it's my pleasure to be with you.
دكتورة حنان احنا نتشرف بوجودك معنا.
I will just give a hint. It's an enzyme activity which might be essential. I'm not going to name the enzyme to give a chance for any other colleague. And
Okay.
this is a case of
yeah, I think Dr. Hanan has put you on the right track.
Yes, this is a case of microangiopathy associating pregnancy and very common.
Fantastic. So
not going to add anything.
Yeah. So the next investigation really is to look at the blood film, and you look at the blood film for several reasons. The first reason is to make sure this is genuine thrombocytopenia, because you could have spurious thrombocytopenia for a variety of reasons. And the other important element, so this is a true thrombocytopenia. If you look at the blood film, there are only 3 platelets you can see. But the most other important finding is these red cell fragments, what we call schistocytes. So these are the hallmark of what we called microangiopathy. Microangiopathy is a relatively rare condition, but a pregnancy and use of estrogen as either as oral contraceptive or rarely as HRT can be a precipitant for TTP in particular. The main pathology is you get fibrin meshwork formed, and as the red blood cells are circulating and negotiating their way through, they get sliced and you get the red cell fragment. And Dr. Mehdi, you're right. In addition to the blood film and the full blood count, we look at other indicators for hemolysis. We look for very high reticulocyte count. We look for reduced haptoglobin, very high LDH, and these are indicative of hemolysis as well as tissue damage. This is in addition to the morphological findings. I've mentioned already, it's important that the coagulation screen is normal, because you could have exactly the same finding in a patient with what we call disseminated intravascular coagulation, where the coagulation screen will be grossly abnormal with low fibrinogen, prolonged prothrombin time, and prolonged ABTT. We will talk about DIC later on. Renal function is very important here, because you wanted to differentiate between is this a TTP or is this what we call a hemolytic uremic syndrome, where the abnormal renal function will be a significant element in the clinical picture. This patient renal function was intact. You can also get other tissue damage related to the cardiac function, and as a part of the routine, we would normally measure cardiac troponin in order to make sure there's no cardiac ischemia. As you can see, up to 60% of patients presenting with TTP will have raised cardiac troponin, but only 10% will have some ECG changes. Now, this condition is an emergency because it is fatal if you don't recognize it and you don't treat it straight away. This is a diagnosis should be done fairly straight away, and as standard operating procedure in all laboratories, you shouldn't really give platelet transfusion, for example, in a newly diagnosed thrombocytopenia before a blood film is looked at and this condition is excluded, because giving platelet transfusion for these patients is a relative contraindication. So the criteria include peripheral thrombocytopenia on the peripheral blood film, mechanical hemolytic anemia, which is the hallmark of microangiopathy, and evidence of organ damage. This patient had abdominal symptoms. She also had altered level of consciousness, so she may have some brain effect already. And these microthrombi, which cause problems, usually get lodged in the kidney, liver, brain, and other organs. So it's very important to remember that you need to check all these organs. In addition to the clinical criteria, there are pathological criteria. This is an endothelial damage condition. There will be swelling, and the endothelial cells becomes detached, and you'll see a lot of thrombi in the microcirculation. I've mentioned the organs which can be affected, including the kidney. Now, TTP, the main presentation is mainly hematological, but you could get neurological symptoms. You can potentially get cardiac involvement, as I mentioned already. Dr. Hanan has mentioned Adams 13 as the enzyme missing here. This is usually caused by an autoimmune condition, but rarely there is a hereditary recessive inheritance type Adams 13 deficiency. The other condition you need to take care of is, or as a differential diagnosis, is this condition, which is hemolytic uremic syndrome. It presents exactly the same: low platelets, peripheral smear showing red cell fragments. But in addition to that, there will be significant renal damage. And this is more common problem at younger age group, in children in particular, which is managed usually entirely differently from adult HUS and TTP. It can be precipitated by Shiga toxin and other diarrheal diseases. So it is some form of a viral related issue. Rarely you can get what we call atypical hemolytic uremic syndrome. This is a complement dysregulation disorder. So people have problems with complement protein H and other parameters. Now, Adams 13 was cloned and discovered about 20 years ago. This is a very important enzyme which is required to maintain the normal interaction between platelets and von Willebrand factor. Now, this is very important to remember. When you cut your skin and you start bleeding, the first step in order to stop the bleeding is what we call platelet plug. So that's formed by the platelets recruited to the site of injury in association with von Willebrand factor, as what we called, it actually practically functions like a glue to glue the platelets into the site of injury to stop the bleeding. Now, once that platelet plug is formed, it has to be broken down. And the breaking down is done by Adams 13. And if Adams 13 is missing, as you can imagine, the platelet plugging will continue to happen. And that element of the regulation with the Adams 13 is lost. And if that happens, then these microthrombi will dislodge in different parts of the circulation. So the von Willebrand factor is very high molecular weight. And without the presence of the Adams 13, it will cause problems by causing the platelets to aggregate, and then it will deposit in the different parts of the organs. Now, the addition of Adams 13 measurement as part of management of these patients has made a huge difference in terms of correctly identifying these patients, because as I've mentioned, the microangiopathy, there is about 5 or 6 different conditions, and you wanted to know, this is the TTP because it has a specific treatment which you need to initiate within sort of 6 to 12 hours. This is what we call plasma exchange. These patients require plasma exchange fairly quickly, otherwise the condition carries between 80 to 90% risk of dying. Now, how does the measurement of Adams 13 help? It can differentiate between these different types of microangiopathy. As you can see, it has a very high sensitivity for TTPs in particular. And if people have low levels of Adams 13, it's almost diagnostic of TTP as compared to other microangiopathy, where most of the time the Adams 13 is within normal range. The Adams 13 is not available everywhere. In the UK, there are about 3 or 4 different laboratories in the whole United Kingdom which have monopolized its measurement, and it is not readily accessible. And therefore, your initial management like what you do in Libya, or I suspect in Cairo or in other places, you still have to manage the patient without the benefit of knowing what is the Adams 13 level. And indeed, this is what the management will indicate. Before you go on and manage the patient, there is a pre-test probability you can use. There are several clinical scores can be utilized, which use platelet count, serum creatinine, ANA, D-dimer, reticulocyte count, and bilirubin level, indirect bilirubin. And you can put these into a scoring system. Now, people who work in the hemostasis and coagulation are very familiar with these scoring systems. We've got a scoring for everything. We've got a scoring for Wells score for DVT diagnosis. We've got a score for heparin-induced thrombocytopenia. We've got a score for Schatzfach score for atrial fibrillation and anticoagulation. We have a score for something called has bled to predict the risk of bleeding in anticoagulated patient. So this gives you an idea. And if you have a high score, this makes the likelihood of TTP almost 100%. And if you don't have access to the assay, you can use these clinical scores quite easily because all the information there can be obtained. These are platelets, reticulocyte count, indirect bilirubin, and so on. And it's accessible to most of us. So what we would do to these patients, once we suspect the condition, we start these patients on plasma exchange, and we start them on corticosteroids. We normally start them on methylprednisolone, 1 gram for the first day, and then half a gram on day 2, and then a quarter of a gram on day 3, and with daily plasma exchange. And, you know, most of these patients will take about a week to 10 days to recover their platelet count. You can use the platelet count as a parameter for recovery. Clinical information is critical to know that the patient is clinically improving. LDH is another parameter we can use for recovery. And I mentioned earlier on, even with the Western availability of plasma exchange, we provide plasma exchange in our center. Even with that, there is still significant mortality and morbidity with these patients. There's still 10 to 20% mortality rate. There is about 30% risk of chronic complications with chronic renal failure, proteinuria, residual thrombocytopenia, recurrence. Now, pregnancy, we didn't talk about specifically about pregnancy here, but pregnant moms who develop this condition have very high risk of recurrence if they get pregnant again. So they need to be counseled properly about getting pregnancy. Now, the new addition to the management of this condition is the introduction of monoclonal antibody cabozantinib. This is a specific anti-von Willebrand factor antibody, which binds the von Willebrand factor and stop it causing the problem of vicious platelet aggregation. In addition to this, most of the patients will be given rituximab, which anti-CD20, as a augmented for immune therapy. But the most important part of the management initially is the plasma exchange and the corticosteroids. Until the platelets recover, that should be done on a daily basis. Okay, we're moving on to the second emergency now.
عفوا دكتور. عفوا دكتور.
اوكي.
معلش المقاطعة. في السؤال الأول في مجموعة جاوبوا في الشات، فهل حضرتك ممكن تدير طلع على الشات باش تعرف اللي جاوبوا، والله هم يرفعوا ايديهم أفضل بالنسبة لك.
Shared 1 second. I don't think Mehdi, how can I access the shared?
دكتور حتلقاها في الشات عندك تحت.
The chat, yeah, the chat. You just hit more, or the chat. Either way, depend. Are you from a computer or from?
Yeah, computer. Yeah.
Yeah, computer. You should see chat by itself. There is in the menu itself and the lower part of the screen.
Okay.
The chat, but I that's okay. They answered. Are you afraid that Because he already mentioned the topics and he passed it, I think.
I'm
No,
sorry.
no, I think for the future questions.
Okay.
Sorry,
Yeah.
I can't access the chat. I don't know why.
No, keep
Okay.
going, Abdulrasaq. I think you're doing fine.
Okay, fantastic. So the second condition is a relatively new concept and new condition. This is, I've given you the date there, which may give you a hint. This is a 46-year-old woman who previously had healthy and fit. She was vaccinated on the 9th of May. She presented on the 15th of May with collapse. She had severe headaches. She had hemiparesis. Her hemoglobin was relatively maintained. She had a thrombocytopenia, normal-ish white cell count, normal prothrombin time, normal APTT. Her fibrinogen was significantly reduced. This is the normal range. Her fibrinogen was 0.7. So the question really is, what would you do as investigation here, or what is the suspicion? Again, Dr. Aisha Ilhani. تفضلي دكتور عائشة.
دكتورة عائشة, unmute yourself, please. Unmute yourself.
Okay, I think
she wrote PDF. I don't know what that means, Dr. Aisha. And somebody else wrote PF4, serotonin assay.
So somebody, they're talking about heparin-induced thrombocytopenia, platelet function for PF4. Okay, what about the COVID vaccine? Does that make you suspect anything else?
They wrote VITT.
Okay, exactly.
Yeah,
okay, VITT. VITT,
okay.
This is exactly what I'm looking for. So this is
that was wait a second, let's give the credit to Dr. Manwa Grain.
Fantastic. Okay.
VITT. Okay.
So this is a case of vaccine-induced thrombotic thrombocytopenia. And actually, this is the first patient of 4 patients we show within 3 weeks around the summer of 2021. As you can see, all of them are women. They all in that sort of age group. They all presented with some form of headaches. These are the days following the vaccination. This is very important part of the taking the history. Most of these people will present from 4 days onwards after having the vaccine. You can get headache with the vaccination in the first 2 days. Everybody gets that. You get like a flu-like illness. As part of that, you get body aches and pain at the site of the injection, and you can get headaches. But we're talking about headaches here, which actually occur 4 days or after, 4 days or later after you had the vaccine, and the range is quite wide. All these patients presented with cerebral venous sinus thrombosis. Some of them presented with more than one area of thrombosis, and 2 of them had in association also subarachnoid hemorrhage. These are the blood results for these patients. As you can see, all of them had a thrombocytopenia with the exception of the 3rd patient. Subsequently, her platelets dropped. The coagulation screens are normal. They all have low fibrinogen except this patient. But characteristically, they all have very high levels of D-dimer. So the D-dimer assay in our hospital is normal range is less than 500. All of them have a D-dimer of more than 20,000. And the other parameters are all within range, including lupus anticoagulant, the coagulation parameters, factor VIII, von Willebrand factor, complement to exclude vasculitic process, and their troponin levels are within normal range as well. So the additional clinical information required really is vaccination history. So this is very important when you see somebody with thrombocytopenia, especially now the COVID vaccine is likely to be with us for a very long time to go. It's very important to make that part of your routine history. Now, these are some of the images for these patients. This patient had a subarachnoid hemorrhage, the green arrow. I don't know if you can see my arrow. there's a green arrow there, which pointed to the subarachnoid hemorrhage for the patient C. Patient A and patient B, you can see the sagittal sinus being lined up. It's quite obviously it's been affected. And in patient D, there's no opacification on the left side of the brain because of the blockage related to the thrombosis. Now, these patients have a very important test you can do, which is the same test we use for heparin-induced thrombocytopenia. And these patients will come positive on this test, despite the fact that they have not been exposed to heparin. We don't really know why these patients develop these antibodies. It could be adenovirus-related issue. The adenovirus is what is used in the mRNA as AstraZeneca vaccine, which has been the culprit in these cases. Now, this is VITT, as suggested by one of the attendees, a new condition that was brought up in April of 2021 associated with the vaccine. By that time, we had almost 20 doses of the vaccine being given at the end of March of 21 in the UK. 33 million were given, 20 million of them were actually AstraZeneca, and the rest were Pfizer and the others. And this was associated with cerebral venous sinus thrombosis, in addition to subarachnoid hemorrhage, and low platelets, a high D-dimer, low fibrinogen, and this became the hallmark of the diagnosis in these patients. I've mentioned the heparin-induced thrombocytopenia, a platelet factor 4 antibody specific, and it has to be the one done by immunoassay rather than by the functional assays, because if you look using some form of AccuStar or other analyzers, these will not be positive. Now, by the end of March of 2021, 79 cases were reported, 19 of them died, 51 of them were women, and the great majority are younger age group. Most of those who died, unfortunately, are below 50. The great majority had brain sinus venous thrombosis. And they also had other unusual sites like abdominal thrombosis, upper arms, and so on. And almost universally, all these patients presented after the first dose of the vaccine. Now, what would we do for these patients? We would start them on corticosteroids in the form of dexamethasone. They all plasma exchanged, and they all have additional anticoagulants. And it's very important to avoid the use of heparin because they behave exactly the same like patients with heparin-induced thrombocytopenia. So these are two patients we looked after. The first patient was given argatroban, which is direct thrombin inhibitor, by continuous IV infusion, and then we converted them to fondaparinux once they became better. This is subcut single daily injection, and eventually they moved on to direct to a DUAC, a Bixaban, prior to discharge to the community. And as you can see, the D-dimers dropped down. The D-dimers are the top green bar. They were very high, and then they came down. The platelet count rose in the middle there. The middle graphs represent the platelet count. And the fibrinogen at the bottom, you can see the fibrinogen as time goes on, returned to normal range. Right at the bottom, there's the optical density, or OD. This represents the positive HET screen. And as you can see, the optical density come down as time goes on to become almost zero or within normal range. Now, if this is recognized early, you can definitely help these patients, but if it is not recognized, unfortunately, it can be a fatal condition, as the statistics has suggested. A very similar condition, which is heparin-induced thrombocytopenia. On this occasion, that patients are given heparin, and they develop thrombocytopenia. Usually more than 50% drop of the original platelet count. It has to be the appropriate timing. between 5 to 14 days after starting heparin. And then this condition is associated with thrombosis. It can be venous or arterial. It can be also associated with an unusual skin lesions. It can also cause anaphylaxis after the injection of heparin. And it's important to remember those. This is what we call the 4T, the 4T score. When we look at these patients, we try to score and see what is their 4T score in order to identify what is their pre-tested probability for heparin-induced thrombocytopenia. The more T's you have, the more likely that this patient has developed this condition. And therefore, it's very important to test for the HIT antibody in order to confirm the condition to start the appropriate treatment. These are the different T's for the T-score, and these are the different scores awarded for the different components. And your score, if it is between 6 to 8, this is highly likely to be heparin-induced thrombocytopenia. If it is low score, it's not likely. If it is low score, please do not test for the HIT, because you may get false positive HIT antibody tests, which can cause a problem for you interpretation-wise. Now, for the intermediate score, it is possible this could be a HIT, but you need to have further testing. And this gives you a practical guide for these conditions. If the score is intermediate or high, the first thing you need to do is to stop giving the heparin immediately. And then you substitute the heparin by a different anticoagulant, which is not heparin-based. So we've mentioned earlier on argatroban, we've mentioned fondaparinux, the danaperoids can also be used. And then you go on to confirm the diagnosis. Don't wait for the blood test to confirm the diagnosis. Heparin-induced thrombocytopenia is a clinical diagnosis. If you suspect it, you act on it. You can check the blood results later on, but it's very important to do that. The reason for that is this: even if patients do not have evidence of thrombosis, their risk of having thrombosis within 30 days from having a HIT positive antibody is very high. This is a retrospective data, but it's very significant information. So nearly half of your patient will eventually end by having thrombosis just because of the antibody is driving thrombin generation. And it's very important that you initiate some form of anticoagulation. Now, some of these patients you may not catch because it could be a post-mortem or it could be a cardiothoracic procedure to remove the blood clot from their lungs, like this patient. They could present with severe skin necrosis. They could present with limb ischemia, and they may result in amputation. They could result in skin necrosis at the site of the injection. This is where the heparin has been given, and this resulted in the reaction caused